Again, thank you very much. Now, today I'm going to be wearing my community emergency physician hat, not so much HEMS. Said I've been doing this for a while. I do both community and academic emergency medicine and also HEMS. But today's topic is the reality of replantation, state of the procedure. What do we do when a patient comes in with an amputated finger? Now, the idea of hands, we know, there's this tie with, a person's heart, and it goes way back, and it contains part of their spirit. But there's something about hands, too, that have a long spiritual history. Now, these are cave paintings. They were found in the Pyrenees. They date 20,000, 25,000 years. And what's interesting about these cave paintings of 241 separate hands, 140 were missing fingers. Were they just tremendously traumatic people? Were these ritualistic amputations, or was this artistic license? It's not clear. This was something interesting. I did this about 4 years ago. My interest in agricultural trauma and literature. Robert Frost, who is an eminent American poet, he witnessed a traumatic injury of a young boy working on a farm. And the boy sustained a severe laceration to his hand and subsequently bled out from it. And so this poem, Out, just sort of describes this, watching this young boy die from massive hemorrhage. And I thought it was really sort of interesting. And so myself and Roz Buckland, we did an analysis of this, looking at it as a case study in massive hemorrhage. So that's a QR to the article that was published in JAMA, but it's just sort of a side thing in one of the few cases where hand injuries actually have a mortality. So the number one things, saws. We've all seen this. So let's talk about a case. 78-year-old farmer working with a radial saw. He ends up lopping off about half of his index finger. The distal half, EMS gets on scene. The bleeding's controlled. He has no other injuries. So there's a level 2 trauma center that's maybe 15 minutes away or so by ground. But they talk to EMS control, and there's this concern. He has an amputated finger. Maybe he needs to go to the big house. So they dispatch the helicopter because, again, we got to get him there fast because, time is muscle and it's very important, but we'll find out maybe it isn't. He was flown to the large tertiary hospital about 100 miles away, and he arrives about 80 minutes after the injury, and he comes on scene. So about 80 minutes. So we'll talk about the end, how this ended up. But as I said, hands, there's something about them. When you look at injuries to the finger and hands, there's not a real big mortality or morbidity. People don't die from these. But you can say the same about ocular injuries, but being blind is a terrible thing, and it can really impact your functioning as a human being. And the same thing with your hands, losing a finger if you're a surgeon. 2 years ago, I was out running and had an out-of-hospital cardiac arrest. One thing led to another, and I had quintuple bypass surgery. Amazingly complex. Those guys are wizards. It was like 9 hours. But minimal post-op care. I was back to work in 9 weeks, and I was probably back to work at 110%. I was feeling better. At the same time, a childhood friend of mine, he's a surgeon back in Ohio. He has similar interests in farming and things like that. He was working on a tractor. The boom came down, and he amputated his index and ring finger on his hand, index and middle finger. It was a zone 2, and we'll talk about the zones. He underwent replantation and extensive hand therapy for about close to a year. And here he is, it still doesn't work right. And so that injury has essentially ended his career as a surgeon. So something simple as a hand injury can have a profound effect. Hand is the tool of tools. Aristotle said that. So the first successful digital replantation was done by Komatsu and Tamiya in 1967. Japan is sort of the epicenter of digital replantation. There was a technological breakthrough that came through in 1967 that allowed him to do this. Does anyone know what that is? Yeah, the operating microscope, because when you get into these guys are amazing, these tiny vessels, digital arteries, nerve sheaths, and to repair those using an operative microscope. And it's interesting, the whole culture, and we'll talk a little bit about that, it seems to be more in Japan and Asia where they do most of the replants and most of the literature comes from there. So, success. What allows us to replant a finger? The mechanism of injury, as you can imagine, a guillotine versus a crush. We'll talk about that. Where exactly it is, we'll talk about the different zones on the hand. Patient factors, are they diabetic? Are they anticoagulated? How old are they? Ischemic time, you think it's a huge factor. You got to call the helicopter. Maybe not. And it's a big thing in the United States, and this probably limits things more than anything, is finding an experienced surgeon and team who are willing to do the replant. And as I said, the rehabilitation, you don't just pop the finger on and you're good to go in a week. It requires extensive physical therapy and very specialized physical therapy. So my rule of fingers is that the patient will almost never present with an ideal traumatic amputation which matches the textbook indications for replant. And the corollary to this is that if a patient does match textbook indications, an available or willing hand surgeon will not be located. Mechanism of injury. This has a lot to do with the ability to replant the finger. Wisconsin, we see a lot of these. Snowblowers, I've seen in a 24-hour shift, wet, heavy snow, 22 separate hand injuries in a 24-hour shift. Most often, the distal part, the amputated part, is not usable. It's hamburger, it's crushed and very injured. The most common cause, especially in children, doors. They get their hand in the hinge, someone closes the door, and those tend to be multiple amputations. Power saws. Farmers, these are the two big ones, chain drives and pulleys. They get their hand caught, takes off the tip. These typically aren't amendable to replant. And ring avulsions, a common thing where you're either jumping over a fence, the ring gets caught, and basically degloves the finger or amputates the finger. So it's common sense. The ones that we're going to have the best survival are going to be the sharp and guillotine type injuries. Avulsions, not so much. You get this stretching and you damage the intima and they require more grafting. They're not usually amendable. And then crush injuries. When you have a lot of soft tissue injury, you get swelling, which affects not so much the arterial, but you can have arterial damage, but the venous drainage from the replanted part is very important, and they don't do as well. But it all comes down to really arterial intima damage and the soft tissue condition. Now, these are the consumer products most associated with amputation in the United States. Power saws, as we said, doors, lawnmowers, they don't get replanted too often, knives, food processors, log splitters, and so on. But, pretty common sense. Now, these aren't the industrial ones. But, okay, trivia question here. We were talking about this in the bar, so those of you know. The Simpsons. All of the Simpsons have 3 fingers and a thumb. Every character on all of the Simpsons show except 2. There are 2 characters that have 4 fingers and a thumb. Does anyone know? It's God and Jesus. When they make an appearance on The Simpsons, they're the only ones with a normal hand. Okay, so indications for replant. Amputation in a child. We already know children really heal well. I've seen dog bites and all sorts of, soft tissue injuries that heal without scarring. And the same thing goes, the vascular repair, and they've shown that, they definitely have enhanced neural rehabilitation. The nerves grow back better and they get better function than an adult. The thumb, that's an important one. Even, because that's our grip. That's what separates us from most of the other animals. But who was that? Isaac Newton. In the absence of any other proof, the thumb alone would convince me of God's existence. And that's true. So in some situations, I've seen this with a snowblower. Again, the thumb is just destroyed. There's nothing left to replant. In these cases, they'll actually do a re-implantation. They'll take the great toe off the foot and graft it on to the stump and connect the tendons, the nerves, and you actually can get very good function. The cosmesis is a little bit funky, but it actually works. Multiple digit amputations. As you can imagine, the one thing about this is, it depends on the zone and also at the level of amputation. They need to be pretty much at the same level. If you have different levels, it really complicates things. Mid-palm amputations, surprisingly, you'd think, wow, this is going to be hard. These actually do pretty well. Again, if you have an experienced surgeons, I've seen several of these and come back with decent function. So anytime we talk about hand injuries, tendon injuries, whether it's extensor or flexions, you got the Verdun zones. So zone 1, those are the ones that replant and they do very well. That's probably about the middle phalanx in the middle, distal to the insertion of the flexor digitorum superficialis. If those are put on, they have a very high rate of survival, and we'll talk about survival and function. Zone 2 is sort of a no man's land. You have more complex tendons, things are in a tighter area, and so even if you replant them and you get good vascular function, you can get a lot of scarring and sort of tendon dysfunction. And that's the problem. If you have a finger that's there, it's being perfused, it's warm, but if it's stiff and doesn't move, you've got a problem. Relative indications for replant. Said a single digit amputation. A lot of times, a single digit they really don't mess with unless it's the thumb. And again, it's in that zone 1, distal to the insertion of the flexor digitorum superficialis. And then in the avulsion injuries, I call these the Hearns syndrome. Because for those of you who know Stephen Hearns, this was after smack in Germany. He was out with his sons and they were going out to dinner and they were cutting across a lot and there was a chain link fence that they hopped. Classic injury. He caught his ring finger on the fence and sustained an avulsion of his ring finger. And there was at Retrieval about 3 or 4 years ago where he gave his pre-dinner talk describing the whole saga of having a revision amputation done in a German emergency department. So what are the patient factors? Chronic disease affecting microvasculature? Sure, people with vasculitis, lupus, people with diabetes. What is their age? Is it the dominant hand or non-dominant hand? Religious and ethnic issues. I've come across this. In certain ethnicities, missing a piece of a digit or a digit is extremely disfiguring, and there's social stigmata associated with this. It's associated with a criminal element. So, in a lot of cases, they're going to want to replant. And what is the patient's occupation? Are they a surgeon? Are they a farmer? Are they an accountant? But the big thing too, and I've found this is the limiting step, are they willing to go through the extensive and rather intense physical therapy needed after surgery? Now, smoking. I remember learning very early that's almost a contraindication. If they're a heavy smoker, you may not want to replant the fingers because of the microvascular disease. But they've done studies, again, out of Japan. Is it a risk factor? And no, they found that smoking alone did not affect the replant outcome. The risk factors for replant failure in this study were older patients and the mechanism. As we said, crush type injuries don't do as well. So ischemic time, this is a big thing. This is why people are calling the helicopter. This is why they're rushing and not looking at things. You just got to get them to the trauma center. It's all about muscle mass of the amputated part. It's one thing, the more muscle, the less ischemic time you have. And that's common sense. If you have an amputated arm, you have a lot of muscle, sure, it's lower. As you get into the hand, but when you get into the finger, there's actually very little muscle. So, in almost all studies, ischemic time rarely influences the decision or the outcome with replant. Typically, warm ischemia. If you take that finger, wrap it up in a gauze and put it in your pocket, you have 12 hours before ischemic times would actually affect the outcome of replant. Now, if you put it on ice, and I'll talk about this in a minute, you have almost 24 hours. So we really don't need the helicopter. And there's studies in Japan and out of China to show successful outcomes, 25, 33, 42, even after 94 hours cold. The finger is warm and perfused. So essentially, there is no time-dependent lesion when we're talking about amputated fingers. Digit preservation, I'm sure you all know this, but I've seen people come in. Number one, you never put the digit and immerse it in water and keep it in water. You want it, you do some gross decontamination, wrap it in a moist gauze, put it in a watertight bag, and then put it on ice. You don't have the finger directly on the ice, and you never, ever, I've seen situations where for some reason they thought dry ice would work better. You destroy the distal part. So why is Asia, again, looking at all the literature for this, I would say, 80% of the big studies, they come out of Japan and China. And people were saying, well, is it due to the cultural thing? As I said, in a lot of cultures, there is stigma about having an amputated finger or hand. And so is that part of it? Or, they talk Confucianism, where the body needs to be buried intact at death. But more likely, it's just sort of a medical culture thing. You had these pioneering microsurgeons, and they passed on and trained others. So it's just really become the standard. And I mean, it's just night and day if you look at the literature and the volumes of procedures done in Japan and China compared to the United States and a lot of Europe. This is one study. 13,000 digits in a 6-year period. They attempted replant on about 13%. The replants were more frequently attempted on the older and the younger. And as we figured, an academic institution, 36% attempted, non-academic, 11%. The success rate in this study was about 90%. Meaning that 90% of the time when they put the finger back on, a couple weeks later, it's warm, it's not necrotic, it's there. But the literature reports anywhere between 60 and 90%. But that's the question. What is success? This isn't plastic surgery where we're putting on a nose or an ear or something like that. The hand is the intricacy and the movement needed. When these studies talk about success, they're talking about sort of vascular success. The digit is warm, it's perfused, it's not necrotic. Hey, it looks pretty good. But in reality, we're concerned about function because you can have a finger that looks good, and if you have a stiff finger that's insensate and not working, it not only doesn't work, it can interfere with the grip of the hand, and you'd be better off without it. Active range of motion is one of the measures of function, and also sensation. You want, at minimum, protective sensation, but a lot of people post-implant develop cold intolerance and chronic pain. And this was one of the early doctors and the early pioneers. His philosophy, and this is true, when you're talking about survival without restoration of function is not success. So the exact same surgical outcome for one patient could be a spectacular success. Say it's a young girl who lost her pinky finger and it doesn't move well, but hey, the hand looks good. She's perfectly happy. But you take that same hand on someone who's a surgeon or uses their hand and that's stiff and it's not functional, that would be considered, a failure. So in the US, we have a problem. We don't have a lot. Someone I was reading recently, only 15% of major institutions are actually doing digital replants. And we have a problem because the availability of experienced surgeons. The plastic surgeons and orthopedists aren't doing these as often. And why? Money drives everything. Having people on call, having people available to take care of these patients. Insurance. There's one study that shows private insurance much more likely to be replanted versus someone with Medicare or Medicaid. So it's not real difficult to identify contraindications to replantation. So a lot of times they'll just opt for the revision amputation, which can be done in the emergency department. So let's go back to our farmer. So they've flown him 100 miles and he's sitting down with the hand surgeon. Now this was pretty unique. Remember how I told you that you need to put it in a plastic bag on ice? Well, in this case, this is what the finger was transported in. They figured, well, we're not going to mess with it. We'll just take the saw. So they brought that on the helicopter. But what was interesting, does this patient meet replant criteria? Yes, relative. It's a single digit, but clean cut through the middle phalanx in zone 1. Yeah, we can put that finger back on. The hand surgeon discussed the replant procedure, recovery, and the rehab with the farmer. So he's a farmer, so he calls his wife, and she didn't even know where he was. He was like, yeah, I'm in the hospital. I cut off my finger. She goes, the whole finger? No, it's the one right next to the whole finger. But anyway, after they explained to him that the idea, we're going to be able to put this finger on, but you're not going to be able to use the hand for several months. You're going to have to come in 3 times a week for rehabilitation. Then there's probably about a 70% chance that hand's going to work really good. And he's just sort of looking at him and he goes, what do you say we just lop the fucker off and call it a day? And that's exactly what he went for. So they did a revision amputation. They did it right in the emergency department. They rongeured it back, did a VY flap, and he went home that day. So the issues with this: should the patient have been taken to the local hospital? Absolutely. They had an orthopedist there. They could have talked to him. Now, granted, if they decided to go for the replant, they would have to transfer him. So in this situation, we can do telemedicine, even just an iPad or sending photos. The hand surgeon could get a good idea of what's going on. But more beyond the mechanism, are there other issues? Most importantly, when you explain what's involved with the replant and the revision, does the patient, after all that, decide they want to have the procedure? So the big takeaway point is there's rarely, if ever, and this just makes me bleed out my ears because I'll see it work in the emergency department 5 or 6 times a year. We get these patients flown from 100, 150 miles away for this emergent procedure, when in reality, the majority of the time they don't get the replant, but they could have saved them the time, the cost, and the risk of HEMS by just consulting a hand surgeon. So we were so preoccupied with whether or not you could, you didn't stop to think whether you should. So, there are definite indications for it, and there's some fabulous results. So in summary, use common sense. If it's a snowblower injury, you don't need to consider replant. You may need a hand surgeon. There's seldom, if ever, a time-dependent lesion. Telemedicine is huge. Before you make the decision that they need to go, talk to a hand surgeon and find out, what exactly is going on. Identify the patient's priority and expectations and explain, it's not only post-op. We don't just pop on the finger and you're done. There is long-term recovery process and extensive physical therapy. Okay, well, thank you very much. Okay.
Thank you very much, Mike. Now, I just want you to stay there.